Hi, Dr. Heino here. We are going to have a series of very short lectures that help support our new guidelines that we're going to be coming out at the end of May 2020 on our Tiny Baby program. These are respiratory guidelines that we've done a lot of research for, with looking at different programs, how they run their respiratory strategies for their tiny babies, for their extremely low birth weight babies, and it is a work that's in progress. We thought it would be a good idea to get everybody on board, do some review lectures, very short, looking at 5 lectures. The first lecture today will be on just some simple terminology, reviewing a couple things that will help you remember what we're looking at when we have a ventilated patient. The second lecture will be on reviewing the conventional ventilator. We use the Draeger. We'll be talking about some of the terminology. We'll be talking about some of the things to look for, troubleshooting when you have a baby on the Draeger. The third lecture will be looking at high-frequency ventilation. We'll be looking mostly at using the jet ventilator, because that's what we use in our NICU. But we'll also touch on the oscillator and some of the terminology that we use for the oscillator. The fourth lecture will be going over the actual respiratory guidelines we want to put out for our tiny baby program. These guidelines are subject to change. Over the next 6 months, we're going to want a lot of feedback on how these guidelines are working for your ventilated patients, your ventilated extremely low birth weight patients. We will be providing feedback as well, and at the end of our 6 months, after we look at all of the data, we might be tweaking these guidelines a little bit. So your input will be very important. The fifth lecture is really up to you. We're going to have a way that you can ask questions either by email or putting them in a sign-up list in the nurses' lounge. And we will spend the fifth lecture answering those questions so that everybody can hear the questions and concerns of everybody in the unit. For respiratory physiology or for questions on the respiratory guidelines, I'll be answering your questions. If you have questions on troubleshooting the ventilators or questions with respiratory therapists, Rose will be answering your questions. And then if there are issues that we have with nursing care of the baby, Sonia or Nina will be answering your questions. So to get started on lecture 1, we're going to be talking about simple terminology. So before we start talking about ventilation or using a conventional ventilator, we just have to understand what we're trying to accomplish. We're doing 2 things for the baby. 1, we're providing oxygen or oxygenation, and 2, we're doing ventilation, which is simply removing carbon dioxide from the baby. We're breathing for the baby. So oxygenation is just delivery of oxygen into the blood. We use it by either giving increased oxygen or we use it by increasing our PEEP. And we'll be discussing PEEP in a minute. If we increase our PEEP, we basically are increasing our surface area of the amount of lung we are using, so that will increase our oxygenation. Oxygenation is also slightly increased by the increase of the peak inspiratory pressure, and we'll talk about that in a second. Oxygenation is monitored either by the pulse ox or we look at the PO2 on our arterial blood gas. Oxygenation or the PO2 on a capillary gas does not tell us anything about oxygenation of the baby. When we look at ventilation, the removal of CO2 from the blood, we can influence that by either increasing our rate, which will increase our CO2, or we can change the PIP, which increases our CO2 removal as we increase the PIP. The only way we have to monitor our carbon dioxide in the baby is by a PCO2 on a capillary gas or an arterial gas. We can use a venous gas, but it's not as accurate. So now we're going to talk about some terms that we use when we are looking at a conventional ventilator mostly, but you need to understand them when we're talking about any form of artificial ventilation. And because I like visuals, I'm going to use my handy easel over here. So the easiest way to understand PIP and PEEP and other issues like tidal volume or inspiratory time, which are all terms that we use when we look at ventilating the baby, is we look at time down here, and we look at pressure over here. So when we talk about PEEP, we talk about the pressure that is there, that we are providing at the end of the expiratory phase. In other words, it's always there. So we usually use a PEEP around 5 or 6. It can be as high as 8 or 9 if we're using other modalities, but we'll say it's around 5. So here's our pressure of 5. Here's 10, 15, 20, and we measure pressures, in centimeters of water. So here we are at 5 centimeters of water, and that is our constant pressure that we're going to provide this baby. It helps keep the lungs open. It keeps the alveoli open. It helps us with oxygenation. We will look to see if we have the proper amount of PEEP, depending on how much oxygen we're using and what the x-ray looks like. If the x-ray is well inflated, chances are PEEP is pretty good. If the x-ray shows that the lungs are overinflated, then we're using too much PEEP. So that PEEP is there all the time, positive and expiratory pressure. Then we have to tell the ventilator to give some type of peak inspiratory pressure. This is what's going to make the baby have breathing. The chest is going to move, and that's how we can tell whether our ventilator is doing its job, is if the chest is moving. Just like when you look at someone, you can tell they're breathing because their chest is moving. So we put in an amount of pressure, or sometimes volume, increase the pressure in the lungs, and it gets to some peak inspiratory pressure. Let's say it's 20. The amount of time it takes to go from here, the PEEP, up to the peak inspiratory pressure is inhalation. It's just like when you take a breath in, when you inhale, this is what's happening to the baby. And this time from here to here is called our inspiratory time. And we write that by TI. Inspiratory time from here to here. Once we reach our peak pressure, the ventilator shuts off, and the pressure drops back down to the level of our peak. It's as simple as that. Inspiratory time, and we allow the lung to relax. And let's say this is 1 second, this is 2 seconds, this is 3 seconds, and if we have a respiratory rate of 60, we have a whole respiratory cycle in 1 second. So now, we start up again, 2 seconds, a second later, we have the third cycle. So during this part of the cycle is when we're going to have oxygenation, and this is when the baby this is the expiratory phase, breathing back out. This is the expiratory time. This is when we have CO2 removal. So inspiratory time, oxygenation, and the baby has expiration, CO2 removal, and then the cycle starts all over again. So by manipulating our inspiratory time, if we make it a little longer, we have longer time for oxygenation. If we make it shorter, we have a longer time for CO2 removal. So if we want to increase our oxygenation, increase our inspiratory time. If we need to remove more CO2, we can decrease our inspiratory time. It's that simple. Okay, so PIP is our peak inspiratory pressure. It's the amount of pressure required to deliver a breath or to move the chest. And it's going to influence both oxygenation, but mostly ventilation. The PEEP is the positive end expiratory pressure. It's constantly applied to keep the lung expanded, and it increases our gas exchange surface area, and it mostly affects our oxygenation. So the inspiratory time is the time for the inspiration to be complete, and it's related to oxygenation. We mostly use 0.25 to 0.4 seconds. The mean airway pressure, you hear us talk about mean airway pressure all the time. The mean airway pressure is calculated by the ventilator, and it uses the PIP and the PEEP and the inspiratory time and the respiratory rate, and it looks at the amount of pressure transmitted to the airway through the entire respiratory cycle. When you have a high mean airway pressure, that means you need a lot of pressure and a lot of support to inflate the lungs. If the mean airway pressure is low, then you don't need that much pressure, and the baby is getting close to extubation. So, what does it mean if the mean airway pressure is low? Low is good. That means we're using very little support, we're causing very little trauma to the lungs, and the baby is probably close to extubation. If we overshoot and use too much ventilatory support, we cause the MAP to be too high. So just like if we cause too much pressure, if we use too much pressure, we can make a pneumothorax. If we use too much pressure and eye time and respiratory rate and PEEP, we can not only cause a pneumothorax, but we can actually reduce cardiac output because we increase the whole pressure in the thorax, and it can actually squeeze the heart, and the heart can't pump as well. You'll hear us talk about tidal volume because tidal volume is the way that we also tell the ventilator to work. We tell the ventilator to insert a certain amount of volume into the lungs, not a certain pressure, and we will go over all of this when we talk about the conventional vent or the Draeger. So the tidal volume for the baby, though, is the volume of gas, either inhaled or exhaled, during a breath. Usually, we want the tidal volume to be around 5 to 6 mLs per kilogram as the tidal volume. Sometimes with different diseases, they need a higher tidal volume, but we start around 5 to 6 mLs per kilogram. If we are looking at the ventilator and we say the tidal volume is too high, it means that we're giving too much volume to the baby and will lower our support. The next thing we want to talk about is the delta P. So that little triangle there before the P means delta or change of, or you can just say the amplitude. Delta P is simply the difference between the PIP and the PEEP. The delta P is what causes and affects ventilation or the CO2 removal. So to decrease the CO2 level in the body, we have to increase the delta P. So in order to increase the delta P, we have to either increase the PIP or we lower the PEEP. Anything that will change that range between the PIP and the PEEP will increase CO2 removal. If the CO2 level is too low and we need to increase it, then we just have to decrease the delta P by either lowering our PIP or by increasing our PEEP. So is the delta P an actual number? Yes, it is. It's the difference between the PIP and the PEEP. It's very simple. So let's say the baby is on a PIP of 25 and the PEEP of 8. Well, then the delta P is 17. So we're going to be using those numbers, especially when we use high-frequency ventilation. So some of the things we wanted to talk about also is the way that we look at evaluating the baby. We get a lot of x-rays when the baby is on a ventilator. One of the things we're looking for, of course, is ET tube position. So when you have a baby who's ventilated, it's always a good idea to go over the daily or every other day or however often we get an x-ray with the doctor or the NNP, just so you can see what we're looking for and how the x-rays change day by day. Some of the things that people have had questions about are terms that we use. We just wanted to make sure everyone was clear about what they meant. The first one is whiteout. What does that mean? We will come to you and say the baby has a totally whiteout lung. Whiteout is just a global white appearance of the lungs. It's usually caused by overall collapse of the alveoli, which is also called atelectasis. We frequently see it when the baby needs surfactant, or if the baby isn't well inflated, meaning the baby needs more PEEP or needs more pressure. Sometimes we see whiteout right after extubation, and we need to increase the amount of CPAP the baby's on to open the baby back up. When we say the lungs look hazy, we're just talking about a global haziness of the lung fields, kind of a graying out of the lung fields. We usually see that when there's an increased vascular marking. We also call that the lungs look very streaky, and it's usually caused by fluid overload. Frequently we see that in TDN for bigger babies, but we can also see it in the smaller babies when the infant needs Lasix because they're fluid overloaded. When we say there's an infiltrate on the x-ray, what we're seeing are these little patchy white areas of consolidation. where the alveoli are filled with fluid from infection or aspiration. We see that in pneumonia from an infection. We also see it with meconium aspiration. So here's a picture of the one on the left is a normal lung. You can see that the area surrounding that big blob in the middle, the heart, is very dark. The lung there is filled with air, so that it appears dark. You don't see much streakiness. You don't see any kind of patchiness. All the borders, the diaphragm, the heart are very crisp and sharp. It's a normal lung. The lung on the right is got what we call whiteout. It's total whiteout. You can't see any heart borders. You can't see the diaphragm. This baby is globally collapsed, we call it. This baby is in dire need of some surfactant or needs some increased pressure to open up those alveoli. Here's an example of hazy lungs. Hazy lung with transient tachypnea of the newborn, or if the baby's fluid overloaded. You can see there's just global grayness of the lungs. It's not as black. The heart borders aren't as crisp. And you can see around the middle of the field there by the vertebral column, there's just some streakiness. Those are the blood vessels you're seeing. It's because the baby is fluid overloaded. This baby needs some Lasix. You can see on the right side of the baby that there's some areas that are patchy. Those infiltrates are consistent with pneumonia. So this baby probably has pneumonia from infection. If the baby had a meconium aspiration, we would see these patchy infiltrates all over the lungs, and we would see them on both sides of the lungs. But here we just see it mostly on the right. Completes our first introductory lecture on terminology. Our next lecture is going to be on the conventional ventilator, on the Draeger. Rose and I will be showing you some graphics that you see when you use the ventilator. We'll also be talking about some of the modalities that we use, either pressure or volume, when we work with the Draeger. So I'll see you later.